Hello, everyone, and thank you so much for joining us for today's Data to Drive Decision webinar series. We are so excited to be having a discussion today about the barriers and opportunities to increase access to telehealth services in the state of Colorado. Today, we'll be focusing on our collaboration with the Office of eHealth Innovation to conduct several key analyses in this area. We have a jam-packed agenda today. First, we're going to learn a little bit about the Office of eHealth Innovation and their initial request to CIVHC. Then we'll hear from our CIVHC colleagues about the methodology and results from three key analyses: the telehealth equity analysis, the payment variation analysis, and the denied claims analysis. Then we'll go back to our colleague at the state and discuss the future of this work and finish up with a Q&A from the audience. Our presenters today are Ashley Heathfield, Senior Project Manager from the Office of eHealth Innovation, Tanya Cliff, Reporting Analyst from the Center for Improving Value in Healthcare, CIVHC, Dagmar Velez, Lead Intake Analyst at CIVHC, Val Garrison, Evaluation Analyst at CIVHC, and myself, Claire Leather, the Public Reporting Program Manager at CIVHC. So we're very excited to talk to you all today. A couple of housekeeping items. All lines are muted, but please feel free to jump into the chat with any of your questions. We'll have a Q&A at the end where we'll address all the chat questions. This webinar is being recorded, and we will share the slides and the recording on our event resource page at civhc.org. So briefly, before we get into the presentation, in case you're new to us, CIVHC's mission is to equip partners, communities in Colorado and across the nation with the resources, services, and unbiased data needed to improve health and healthcare. Our vision is that everyone have the opportunity to be healthy and have access to equitable, affordable, high-quality healthcare. We are a nonprofit, we are independent and objective, and we are service-oriented. Who we serve. So we serve a variety of what we call change agents, which are individuals, communities, or organizations with the boots on the ground trying to improve healthcare in Colorado. This could be clinicians, hospitals, health plans, researchers, you name it, anyone who's touching healthcare with the focus on the consumer at the center of it all. So how we serve. One of the ways we serve is that we are administrators of the Colorado All-Payer Claims Database. We call it the Colorado APCD for short, and we turn this data into what we call public and non-public data, which is what we're going to be discussing today. We'll also be talking to someone from our research and evaluation services team. We also provide a lot of community engagement work and have programmatic expertise in advanced care planning, palliative care, and aging. As the public reporting program manager, I do have to plug our public reports. This is a list of all our publicly available data on our website. You can also download the underlying data for most of these. These are all interactive tableaus and cover a wide variety of topics in healthcare. So enjoy. Quickly, we do want to discuss what is in the Colorado APCD. So we have medical, pharmacy, and dental claims data going back to 2013, totaling more than 1 billion claims, which is huge, which is, very robust. That represents about 48 commercial players plus Medicare and Medicaid. That looks like 5.5 million lives in Colorado and over 70% of the covered lives for medical insurers. We also have trend information that goes all the way back to 2013. So a very robust data set. What's not in the APCD are federal programs such as the VA, Indian Health Services, and TRICARE. They're currently unable to submit to us. We're working with the VA to get VA submissions. And we also don't get a majority of ERISA-based self-insured employer claims. They can voluntarily submit to us, but they have separate federal regulations. And we do not get uninsured and self-paid claims. Now I'm going to pass the baton to Ashley from the Office of eHealth Innovation to hear more about their work.
Thank you, Claire. So a little bit about our office. We were established in 2015 through an executive order responding to the consensus between public and private stakeholders of a need for statewide health IT governance and coordination. So we're housed in the Lieutenant Governor's office, and our team is responsible for defining, maintaining, and evolving Colorado's health IT strategy concerning care coordination, data access, healthcare integration, payment reform, and care delivery. So to ensure these efforts align with the wants and needs of Coloradans, OeHI has created and adheres to a health IT roadmap. We're actually refreshing this in the next year. But we also have our beloved eHealth Commission made up of experts across Colorado's health IT landscape, which advise on our direction and steers the roadmap efforts. So our roadmap identifies 3 major goals to guide our work, and that is that Coloradans, community partners, payers, state, local, and tribal agencies share data and have equitable access to needed health and social information, that Coloradans have access to high-quality in-person, virtual, and remote health services that are coordinated through information and technology systems, and that Colorado improves health equity through inclusive and innovative use of trusted health IT and digital health solutions. Go to the next slide. So the main goal of our telehealth initiatives is really to improve equity and telehealth access for Coloradans and to support community providers in offering and sustaining telehealth services. So to inform this work, we've worked to collect insights, challenges, barriers, and successes of telehealth in Colorado from both patient and provider perspectives. So given today's presentation, I'll focus mostly on our provider work. So to dig more into kind of the needs and experiences with telehealth, actually the previous slide. OeHI partnered with Prime Health in 2021 to establish the Regional Telehealth Learning Collaboratives, or the RTLCs. And the goal of these groups was to advance the statewide adoption and coordination of telehealth technologies. So the initial effort included 3 geographic regions spanning urban, rural, and frontier areas, each served by a regional accountable entity, or RAE, that provided support and encouraged participation among providers and community partners. So through this process, we heard from hundreds of individuals and dozens of organizations statewide, gathering information, discussing models and services, collecting feedback, determining priorities, and it concluded with a collaboratively developed recommendations for an equitable, impactful, and inclusive statewide telehealth infrastructure. And in addition to that, also through a partnership with OeHI and Prime Health, a survey was developed that included insights and questions from more than 25 state agencies and departments, research organizations, provider organizations, and community partners. So an initial survey was disseminated in 2021 and was followed by another one in summer of 2022, and both of those reports are linked here on these slides. Next slide, please. So through these efforts, we learned of several barriers that make telehealth adoption and implementation difficult for providers. This included a crowded space of different entities disseminating telehealth information and training to safety net providers, with many citing confusion, duplicative programming, and time-consuming yet ineffective trainings. We also heard about a lot of different challenges really stemming from using outdated electronic medical record systems, making it difficult to prioritize and invest in digital health technologies, and they reported challenges in choosing which digital health vendor is right for their organization, given the wider range of tools and vendors that are out there. However, most relevant to today's presentation, we found that many providers reported complexities, challenges, and claims denials for unclear reasons when attempting to bill for telehealth, and particularly confusion when it came to contracts with commercial payers. Safety net providers often rely on reimbursement from commercial payers to sustain their practices, so complex billing practices that are costly and time-consuming can lead to adoption and sustainability barriers for these practices particularly. Next slide. So we asked Civic how we could leverage the Colorado APCD to explore payment parity and denials parity to confirm or rule out wide-scale issues with telehealth reimbursement with commercial payers. We also wanted to understand telehealth utilization disparities at a more granular level and explore what social factors may have the highest impact on telehealth utilization, leading to the telehealth equity dashboard. And with that, I'll turn it back over to the Civic team.
Thanks so much, Ashley. We have Tanya to take it over from here.
Hello, thank you. Hello, my name is Tanya Cliff, and as Claire mentioned, I'm a reporting analyst here at Civic, and I spent quite a bit of time working on this report, so I'm very excited to be able to share it with you today. Let's go ahead and start on the goal page, please. The next slide. So as Ashley explained, OeHI was interested in better understanding the relationship between social factors and health measures. These ended up being the two main components of the report we developed. The primary use cases for this project were, one, to understand how telehealth and in-person services are used across the state. We also wanted to determine whether social factors have a relationship to levels of telehealth and in-person service use. And finally, it was very important to be able to use this information to inform programs or initiatives to increase access to telehealth or in-person services in communities. Next slide, please. So the next question is, which social factors were included in this report? The specific detail was pulled from the 5-year average numbers for 2020 from the American Community Survey, and the specific factors we used are listed on the slide. It included a percentage of individuals, people of color, veterans, limited English, disability, unemployed, or without a high school diploma. We also included 3 tech social factors, which were percentage of households without internet, computer, or smartphone. And then there's just a reminder at the bottom, that's fine, that we actually don't have access to the VA database. So, all right, we talked about the social factors we used for this analysis. Now let's define the healthcare measures that were used for the report. There are 2 main components used: the telehealth and in-person service claims from the Colorado APCD, and they are both reported as utilization as defined on the slide. So there's the telehealth utilization, which is defined as the number of visits for any reason, any diagnosis recorded in claims as telehealth, as well as the in-person utilization, which is defined as the number of in-person visits identified using the same set of CPT codes as used above. So that's an important item to note. In-person services were limited to only services that could have been performed via telehealth, and do not include things like surgery or lab tests that required an in-person visit. Basically, we took 2 steps to make these 2 health measure utilization rates more clear and concise for reporting. We only included services that could have been performed via telehealth. This ensures we are comparing the same group of services. We also show each as a rate, which is the visits per 1,000, to make the rates whole numbers and therefore easier to read and consume by the viewers of the report. Okay, so that's all the business stuff. Let's go ahead and jump over to the demo. So this is a screenshot of the first tab of the demo, or the first page of the demo. You can see at the top there's 2 tabs. The first tab is a map and table view, which we'll go through first. And then the second tab is the measure relationship view.
So I'm going to quickly take us into the report.
Thank you. I'm only seeing the top part of the screen. I think.
There we go. Can you see it now?
Yeah, I see the top part. I don't see the report itself.
Going down. Yep.
There you go. There you go. Thank you. All right. So as we mentioned, there's 2 tabs, the map table and the measure relationship. If you recall, one of the first use cases was to understand the telehealth and in-person service usage across the state. For that reason, we started with this map, which is a nice visual overview. As with all the charts in this report, the parameters are at the top. So in this case, we have select county and select measure. From county, you can select all counties or one specific county. Thank you. And then the measure allows you to select either the health measures or the social factors. And then the map, there's a number of different ways to interact with a map. On the left-hand side, there's a zoom that allows you to zoom in and out of the report. Yeah, And then there's also a home button that allows you to reset. So go ahead. Yeah, so that's the home button. So once you start selecting parameters, you can select that home button and it'll set you straight back up to the statewide view. So yeah, Claire, if you would just hold the mouse over one county, please. Perfect. So if you hover over the map, and we're at the county level right here, it will show, it'll have, oops.
Sorry, it wants to, of course, we're live, so it wants to be finicky today.
I know. All right. So yeah, just hover over, just hold your mouse. There you go. Just stop right there. Yeah. So you hover over a county and you can see at the top, we have all the measures for the county. And then at the bottom, we have race ethnicity data that's compared. So right now we're at the state level. So it's comparing the state to the specific county that you're hovered over. So the state is in gray and the county information is in green. So that's one way to get that information. You can also click on that county, and that will allow you to drill in further, and you'll get a view of that county with all the neighborhoods. And you can do the same thing at this map. You can hover over one neighborhood, and you get the same pop-up with the measurements on top for that specific neighborhood. And then the race ethnicity looks similar, but it actually compares the county level to that neighborhood. So any neighborhood you highlight in this county will show a similar map. Okay, that's good. Thank you, Claire. Let's go ahead and roll down to the data table. So the map was a great visual to give you an overview of the trends across the state. We also wanted to include the status sheet that allows you to dig a little bit deeper and compare different measures and counties to one another. So just like the other report, the parameters are above the report. There's geography, and you can click in there. I think the options are all counties, all neighborhoods, or individual counties. There's a sort by, so you can sort by any of those columns. And then the last parameter option is just ascending or descending. So the layout of this table is on the left, we have all the counties and neighborhoods depending on which measure or which geography you select. And then across the top are all the measures, both the health measures and the social factors. And then that orange bar across the top is the state level numbers. And that just stays there so that you can compare depending on what you've selected. So this is a really great report for drilling down to specific counties or neighborhoods. So Claire, if you wouldn't mind, select from the top measure select all neighborhoods. So this, because we have it sorted by county neighborhoods, shows all Adams County, and then the neighborhood number is listed after it. And you can see how this is a nice way to sort columns by increasing or decreasing and allowing you to compare values between different measurements as well as different counties and or neighborhoods. Okay, and then let's go ahead and go to the second tab, please. So the second tab really, we really tried to drill in on the relationship piece of the questions that OeHI was asking. So again, we have two parameters on the top. You can select the measure and then the second one is the county selection. All counties or individual counties. So yeah, let's default. This is perfect. So this report has two scatter plots. The top scatter plot is to show the data points for telehealth visits. So you'll see the telehealth visits are on the x-axis, and then the measure selected is on the y-axis. Below this chart is the exact same chart, but for the in-person visits. So again, in-person is across the x-axis, and the selected measure is on the y-axis. So you can select a measure and then compare the two, depending on which measures you want to see. The most critical part of this scatter plot graph is the R value. So in attempting to define the relationship values, we did this by using the Pearson correlation coefficient, which helps us to provide possible relationships or insight into possible relationships between the two data sets. if you hover over the R value like Claire is doing, you get information about what the R value means, the limitations to the R value. The R value often isn't quite as useful. It really can only provide interpretation on data with 20 or more data points. So in this example, we have all counties selected, so you can see there's a large number of data points, which makes the Pearson coefficient that much more accurate or that much more meaningful. I think that's all I was going to go over. So Claire, I'll hand it back to you. Thank you for navigating.
Yeah, thank you for demoing. I will share my, go back into the PowerPoint here real quick. Okay, I see a couple of questions in the chat. Again, we will try to answer those as in the Q&A, and I am going to cover what we found from this wonderful analysis with all this great data. So at the statewide level, we found that the lack of computers had a moderate relationship to lower telehealth visits. We found that a lack of smartphones had a moderate relationship to lower telehealth visits as well. The lack of access to a vehicle had a moderate relationship to higher telehealth visits. And then veteran status had a moderate relationship to lower telehealth visits. The top 20 counties with the highest telehealth utilization were primarily urban counties. And compared to statewide, these counties also had lower percentages of individuals or households with people of color, without a vehicle, or with limited English. Conversely, we found that the top 20 counties with the lowest telehealth utilization rates were almost all rural, with the exception of Mesa County. And compared to statewide, nearly all these counties had higher percentages of individuals or households without a computer, without a smartphone, without internet, and with disabilities. So those are some key findings. We'll have more to come in the coming weeks to share with you all. But now I'm going to pivot to my colleague Dagmar to talk about the payment variation analysis. So Dagmar, take it away.
Thank you, Claire. So I'm going to go over the report that we collaborated with OeHI which used Colorado APCD claims to determine if there was payment parity between in-person and telehealth claims. So what we did was we wanted to account for the different factors like the variance between procedure code costs and year and so on. So what we did is we constructed 9 different regression models with those different variables, where the dependent variable was the cost amount and the independent variables were the place of service, so in-person versus telehealth, the year, which we used 2020 and 2021 data, place of residency of the patient, rural versus urban, and the procedure code, just to account for the variance. And then we ended up using 8.6 million total claims across 27 commercial payers. You can go on the next slide. So what we found from this was, in general, there was lower reimbursement amount for telehealth visits compared to in-person visits, although that trend improved from 2020 to 2021. In 2020, we saw that 60% of those procedure codes did have a lower reimbursement in telehealth claims than in-person, whereas in 2021, only 40% of those procedure codes had a lower reimbursement. And we did see a trend where that amount did lower, even for those that still had a significantly lower reimbursement. So in 2020, there was a median amount of $29 lower for reimbursement, and in 2021, there was a median amount of $23. So there was a lower reimbursement, but it seemed to improve over the 2 years. For payer, although payer wasn't included in our model, we did see similarities between both years. So the range of how much reimbursement was lower for telehealth. Sorry, payments were ranged from $2 to $59 lower for telehealth. So 85% of insurers in 2020 were reimbursing less for telehealth services, where in 2021, 88% of those insurers reimbursed less. And in 2021, only 8% had equal or higher payments for telehealth. 60% of payers decreased the gap between payments, and 32% of payers showed an increase in the gap between payments for in-person versus telehealth. So for looking at the place of residency, so this urban and rural indicators that we included in the model was based on the members' residence. In general, we did see that there was a significantly higher reimbursement rate for rural telehealth claims compared to urban telehealth claims. And this also seemed like it improved from 2020 to 2021. So you can see for statewide, urban, and rural, the differences in reimbursement rates improved from 2020 to 2021. You can go in the next slide.
Okay, well, thank you so much, Dagmar. We appreciate that. Now we're going to jump into the claim denial analysis, and Val, take it away.
Hi, Claire. Hi, everyone, and thank you, Claire. So as Ashley mentioned in the beginning, with the results of the OeHI survey and the report that was released, they also wanted to assess whether there's parity between the rate of claims denial between telehealth and in-person services, particularly relating to those references to it's a difficult process to even go through submitting and getting a claim approved. Unfortunately, the Colorado All-Payer Claims Database does not have currently denied claims. And so we weren't able to do this kind of analysis using the APCD. So instead, we brought in a partner from the Division of Insurance. And so the three partners worked together to do a separate and smaller analysis to get a general picture of what this might look like. So the Division of Insurance issued a data call to 5 commercial health insurance companies. And what we requested through that data call was individual claim lines for services delivered in the time period for the services that we used for the payment parity analysis. So we tried to match the criteria and the methodology as closely as possible to the claims that were included in the parity analysis. The one exception to that is this data call included all claims regardless of their adjudication status. So the adjudication process is the process through which an insurance company works with a payer or a member to determine whether or not the claim will ultimately be approved or denied. So all of the information in the Colorado All-Payer Claims Database is at its final status in terms of approved. The data that we received may have included claims that were at any stage of that process. So if a claim had been submitted and denied, and then an adjudication process took place, we would still have that initial claim. The reason we did that was we wanted to understand this question about the claims submission and approval process. And so as part of that, we also asked for the payers to include their explanations for why a claim might have been reduced or denied. And we conducted a qualitative analysis of those explanations, and we coded those and grouped them into themes. And then we ran chi-square tests of independence to see if there was a difference in the distribution of denial reasons between telehealth and in-person claims. We also then ran logistic regressions to see whether those differences differed between the insurance company, the service type, or the geography, similar to the payment parity analysis methodology. Next slide. So with that initial assessment, we did find that there was a difference between telehealth and in-person denial rates, with telehealth claims being more likely to be denied than in-person claims. And we did find that there is a significant difference in the likelihood of denial depending on who the commercial payer was. Again, we only had 5 payers included in this analysis. Actually, it was 4 because one only sent us aggregated data. And we also found that that differed by the type of service. Really interestingly to me personally is with that qualitative analysis, we found that telehealth claims were significantly more likely than in-person claims to be denied for untimely filing, errors in the submission, missing information, or any corrections to the information needed. And they were also much more likely to not have a reason added at all in that claim denial record. So we found that these really gave us an indicator that it's worth looking a little bit deeper into this data if possible, and give us some ideas for where to look next. And with that, I'll pass it back over to Ashley.
All right, so thank you, Val. And thank you, Civic team, for just explaining all of this analysis and for your partnership. Looking ahead, what we're going to do with this is actually refresh with Civic the payment parity analysis to see if the trends in telehealth reimbursement disparities are continuing and what the estimated financial impact of these disparities are on providers. So we want to ensure safety net providers are supported in offering and sustaining telehealth services to their patients, and making sure reimbursement legislation is happening the way it was intended is maybe the biggest way for us to do that. We're also, continuing to partner with DOI and keeping them in the loop on this research to see how, if there are continued disparities, what could we do with that information to help get that corrected. And then we are also working to conduct research in Colorado communities with the lowest telehealth utilization based on the telehealth equity dashboard to find opportunities to further our understanding of why we're seeing these disparities and what kind of opportunities are available to help kind of close those gaps. Certainly not every situation is appropriate for telehealth, or some people prefer in person, but we want to make sure that as telehealth is intended to be this tool that really increases access to care for those that have low access to begin with, that those populations really are able to take advantage of this and benefit from this, and it's not really just serving those who already have pretty good access to care. So, and with that, I think we're going to go into the Q&A session.
Yes, we are. Thank you for everyone's wonderful presentations and details. You can reach us at info@civic.org. And you can also reach the Office of eHealth Innovation at that web address as well. And yeah, please let us know what questions you have in the chat and we'll be happy to answer them. Val, it looks like there's a question about the denial rate comparison. So I don't know if we want to go back to that slide or if you have that.
Yes, I will just say I saw that question. I'm turning back to the report because I don't remember the exact numbers. So I will pop that in the chat as soon as I confirm that number.
Wonderful. Any other questions? So this looks like a question about the denied claims work as well. Just to clarify, you collected denied claims by asking a subset of commercial payers to submit the claims to you. Val, if you want to answer that.
Yes, that's correct. So the Division of Insurance put out a data call to specific commercial payers. I admittedly am not 100% sure how they selected the payers to reach out to. And so the commercial payers responded to the data call and sent the claims to us. And then we cleaned that data and applied a methodology to determine which claims were denied versus approved. And then we proceeded with the analysis from there. So none of that data came from the Colorado All-Payer Claims database.
Thanks, Val. Any other questions? Oh, Ashley following up. Yep. Largest payers in Colorado. That's how DOI selected it.
Yes, we did need to collect all claims so that we could compare the in-person to the telehealth and the approved to the denied. So we needed to have not just the information about denied telehealth claims, but we needed the information for approved and denied telehealth and in-person, which is why we asked for all claims.
And this looks like a question for Dagmar for the payment variation analysis. Curious about payment differential. You were comparing same level of claim level 3 tele versus telehealth, I'm guessing, versus claim level 3 in person.
Sorry, I don't understand level 3 in that. I
Can you
don't know what that means.
Yeah. Dr. Keller, if you could clarify just a little bit what you mean by level of claim in the chat. We could always follow up with you as well post. E plus M code. Oh, you can unmute him, Steph. Great. That would be helpful.
So, I don't know if this will help clarify that question, but we did only include procedure codes that were available to be given both in person and telehealth. There weren't any claims that were included in the report that were only able to be given in person.
Okay, so for an evaluation and management code, which is the most common code that we use when we're doing telehealth, there's different levels of the code, 2, 3, 4, and 5, depending on the complexity of the question being asked and the complexity of the response. So when you were comparing the payout for claims, did you, I presume, because when I bill a variety of those things depending on what the question or depending on what the visit was. You were comparing the same level of claim against the same level of complexity in the in-person visit? Or did you just aggregate all of the in-person visits with the same codes and compare it to, because that would might bias you. I tend to use the lower level codes in my televisits. They tend to be my easier visits, and I tend to do my harder visits in person.
You know, that is great feedback because I did not know that. I only aggregated them at the CPT code level. So if there is a more granular level than that,
No,
then I
they're
need
within these are CPT
Okay.
codes. So you are comparing same CPT code.
Yes.
You know, basically the telehealth is a level 3 CPT code with a modifier to say telehealth. That's all. Okay. So that's what I was just checking to make sure that we were allowing for complexity of visits.
Right. Yep.
Okay.
Wonderful. Thank you so much, Dr. Keller, for your question. Any other questions from the audience? And just to say again that the slides and the recording will be made available at our website, civic.org, on the events page. And there's Val answering, I believe, Christina's earlier question. Thank you, Val, for getting that. Those numbers from the report, you're so fast. Okay. If there's not any more questions, I think we can wrap it up. I just want to thank Ashley for her collaboration, going hand in hand with all this work. So thank you for all of your brain power and time and energy and focus on this really important topic. And thanks to our civic colleagues for all the work that they've done on all these wonderful reports. They can all be found on our civic.org webpage under telehealth analyses. And again, feel free to contact us with any of your questions that you didn't get to ask today. Thank you so much for joining us. See you again. Bye-bye.